Hello, good morning, good afternoon, good evening, or good night, wherever you are. Welcome to another installment of the A&T Neuro webinar series. My name is Martijn Schreuder and I'm the CEO of A&T Neuro. Now, I'm particularly excited about this webinar, both for the speaker that we have with us, but also for it being the inaugural webinar to celebrate the launch of A&T Neuro Australia. As of about 2 months ago, A&T Neuro Australia opened its doors out of Melbourne, and it is now ready to serve its current and future Australian customers directly with the high quality service that everyone has come to expect from us. We are very excited about this development and we look forward to touching base with you soon. Now, to kick off the webinar, I would like to hand the word to Dr. Shung Chung. That's our sales engineer in Australia. If you are located in Australia, I do encourage you to get in touch with Dr. Shung after the webinar. We will share his contact details through the chat. Shung, the floor is yours.
Thanks, Martijn. Hi, everyone. My name is Sung, and I'm the sales engineer at A&T Neuro Australia. As is customary in Australia, we would like to acknowledge the traditional custodians of the land on which our offices stand, and we pay our respects to elders past, present, and emerging. We're very happy to be hosting today's session on precision neuromodulation in psychiatry, neurotechnology in clinical practice, presented by Professor Paul Fitzgerald today. Professor Paul Fitzgerald has been involved in the development, evaluation, and clinical implementation of new treatments for mental disorders for about 20 years. He's pioneered the use of TMS in Australia and is internationally renowned as a leader in the field of brain stimulation and device-based treatments in psychiatry. He's published over 400 peer-reviewed journal articles and book chapters and conducted an extensive series of research studies and clinical trials. He's currently continuing this research and clinical works as the director at the Epworth Centre for Innovation and Mental Health in Melbourne, Australia. Professor Paul Fitzgerald, thank you for accepting our invitation and being with us here today. The screen and the stage are yours.
Thanks. Thank you very much, Sung. I will just start by showing you, as is custom, my disclosure slide, which is interestingly, I don't think changing. Oh, here we go. There we go. Just to acknowledge a couple of disclosures, particularly that I am the founder of TMS Clinics Australia and Resonance Therapeutics, and on a number of, and have been or are on a number of scientific advisory boards. So the context really of this whole presentation, in other words, why we're talking about the use of non-invasive brain stimulation and how we should improve that in psychiatry, is that although we have treatments for most psychiatric disorders, a lot of those treatments are really only partially adequate, and we don't necessarily have a lot of emerging new options that are likely to really change that in the foreseeable future. So, I'll mainly be talking about the application of TMS in depression, and depression is a common disorder. It affects up to 15% of people across the lifespan. It's costly to treat. It results in lots of disability. And most importantly, up to 1/3 of patients with depression just don't get better with standard treatments. The data on this slide is a little bit old now. It was from 2010, but things haven't really fundamentally changed all that much. It was really there to make the point that neuropsychiatric drug development the pipeline for neuropsychiatric drug development is pretty sparse. It's more expensive, it's less successful, and takes longer to develop a drug for a psychiatric indication really than for any other application. And so, most companies are not really highly invested in this space. And so we very much need other options. This just highlights the poor outcomes that we have with existing pharmacotherapy for depression. This is data from the STAR-D study. So 3,000 patients with depression treated across 4 levels of therapy. And if I just draw your attention to the bottom right-hand corner of this slide, this shows that once you've failed 2 medications, And this is pretty common. I would never see a patient, would never get a patient referred to me who hadn't tried at least two antidepressant medications. Once you've failed 2 medications, your chances of getting better with the next one and staying well for the next 12 months are less than 1 in 20. So that's really not all that impressive. So although we currently have forms of talking therapy, we have various drugs, we've got electroconvulsive therapy, we certainly need to do a great deal better. And one of those ways to do a lot better is through the development and use of forms of novel brain stimulation therapies. And so there are lots of these in development. Some will succeed, some will fail. We have non-invasive forms of brain stimulation like TMS or direct current stimulation. We have emerging forms of convulsive therapy like magnetic seizure therapy. And we even have emerging forms of surgical neuromodulation such as deep brain therapy. But I'm really going to concentrate today, I can't really say this afternoon because most of you are probably in a different time zone, but I'm going to concentrate today on transcranial magnetic stimulation because that's really the area that I've predominantly worked in over the last 20 years or so. And so for those, I'm presuming most of you know a little bit about TMS, but for those of whom this is not something you know a great deal, TMS is a form of non-invasive brain stimulation that involves using a coil and a current generator to generate a very strong electrical current that is switched on and off very quickly. That's used to generate a very strong but highly time variable magnetic field, which passes into our brain without resistance and induces an electrical field that's strong enough to produce neuronal depolarization and firing of neurons. If we do that on a single occasion, we'll get a big bunch of nerve cells to fire in a synchronous manner. And in a therapeutic context, we are repeatedly stimulating these neurons, so making them fire thousands of times. And it's standard course of treatment, perhaps 60 or 70,000 times. And if you make a big bunch of millions of neurons fire 70,000 times at a specific frequency over the course of a month or so, you're going to change the properties of those neurons, their likelihood to fire in the future, and the strength of the connections between the target zone and the area that those neurons project to. So at a simplistic level, we believe that high frequency stimulation increases local activity and low frequency stimulation decreases brain activity. But these are relatively gross generalizations. And I think the mechanism of action of TMS probably has much more to do with adjusting or modulating cortical subcortical connectivity and activity around a much broader circuit. And so we started to work in this area many years ago. This was data from the first study that we published back in 2003. When we embarked on this study, and that's a very younger me back then, and it kind of showed how we did TMS back then. I literally used to handhold the coil as we would do a course of treatment because I couldn't afford the $5,000 at the time to buy a coil stand. When we started this trial, TMS was kind of waning. There'd been some positive data early on, but then there was some negative data and people were losing enthusiasm. And there'd basically been a lot of very underpowered studies. So even this study, which was quite small, it was only 60 patients, was substantially larger than almost all the other studies that had been done until that time. And we got robust effects showing that a high frequency left-sided TMS, the standard approach that we use now, but also low frequency right-sided TMS, both seemed to be effective. Both were safe, both were well tolerated, and both they produced equivalent clinical outcomes. So we progressed on from there to do a study of sequential bilateral stimulation, combining these two types of treatment, and got fantastic response and remission rates. And really since then have now conducted somewhere close to 20 randomized controlled trials in the time since then, exploring a whole range of variables that we've been interested in as ways of potentially enhancing the effectiveness of TMS. And I'm not going to go through all of those today because we'd be well and truly going over time. But suffice to say, the studies that we've done and that have been done by many other groups around the world have provided us with level 1 evidence of the benefit of high frequency left-sided treatment, low frequency right-sided treatment, sequential bilateral treatment, and perhaps not quite at a meta-analytic level, but certainly at a clinical trial level, also evidence for the benefits of so-called deep TMS, using coils to penetrate further into the brain. So we have a very effective treatment that has a number of different ways in which it can be applied. So what happens when you what are the sort of outcomes you get with this type of treatment? Well, this is data from a study we published a couple of years ago where we pulled data from about 1,100 patients treated in a series of trials from the early 2000s through to the mid-2000 and about 2015. These were highly treatment-resistant patients. So just to highlight, they had an average failed number of trials of around 5 to 6 different antidepressants. They had a lot of comorbidity. So this was kind of, these weren't early stage, easy to treat patients, but were quite complex. And a number of the protocols we used were quite early on. They were what I'd regard as relatively low dose protocols. And despite the challenges with treating these patients, we got a response rate of almost 50%, with another 20% of patients regarded as partial responders, and about a third of the patients who were non-responders. So these were clinically meaningful outcomes, not really significant benefits despite the degree of treatment resistance and the complexity of the patients. So TMS works, it's safe, it's well tolerated, but how does it compare to other treatments? Well, to think about that, we need to go to the area of network meta-analysis. Unfortunately, there was a network meta-analysis, a substantial one published a couple of years ago. So this compared a whole series of interventions that are potentially effective in treatment-resistant depression, including TMS, ECT, lithium, atypical antipsychotics, combinations of antidepressants and antipsychotics, really a whole range of different things, thyroid hormone, et cetera, et cetera. Now, if you were to go and read the abstract of this article, you probably wouldn't be all that impressed. It doesn't really refer to TMS at all. In fact, it kind of talks about quetiapine and risperidone as being the things that were highlighted by this network meta-analysis as being perhaps the most promising things in treatment-resistant depression. And so if you just read the abstract, you would kind of go away feeling pretty negative about it. And I think this has tricked up some of our colleagues. Recently we had a rather negative appraisal of TMS presented in the Australian and New Zealand College of Psychiatrists by some colleagues who are writing some new clinical practice guidelines. And when we referred to this meta-analysis, they told us that no, it didn't really seem to show that TMS was effective at all. But I think they erred by judging a book by its cover. Because, as I said, if you read the abstract, it doesn't show TMS in a very good light. But if you notice, if you read any deeper, the first thing you'll notice is that the authors of this article were either directly employed by a pharmaceutical company or by a contractor who was working for a pharmaceutical company. So that might make you a little bit suspicious. So then if you read further on into the article, you might notice these details. So these are, at the top of the screen, response rates at 4, 6, and 8 weeks. And what it says here was that compared to placebo, response rates were respectively 2-fold, 2.7-fold, and 4-fold increased for aripiprazole, ECT, and TMS. So the TMS response rates were better than anything else. There were only 3 things that worked, and TMS worked better than anything. And if you looked at 6 weeks, there was a higher response rate for TMS than anything else. It was the only thing that actually met statistical significance. So you say, okay, well, maybe they just wanted to ignore response rates because clearly TMS was the best treatment in regard to response rates. Well, what about remission rates? At 4 weeks after baseline, aripiprazole augmentation, TMS and ECT were more efficacious than placebo. So again, it was one of the only 3 things that was beneficial. What about at 6 weeks? TMS showed the highest remission rates and ranked first amongst all competing interventions. So what clearly this shows, despite reading what the abstract would take you to believe, that TMS is a highly effective intervention for treatment-resistant depression, and probably more effective than, or as effective, if not more effective than anything else that is out there. So that's just a lesson not to judge a book by its cover. Now, as I said, so now, you know, we know this is effective, we know it works, but, you know, things can still be improved. And there are a number of ways that we think we still should be working to try to improve the application of TMS over time. And a lot of those have got to do with personalisation and individualisation of treatment parameters. And that's kind of some of these areas is how I want to spend the rest of the time we've got today. One of the main issues around personalisation of treatment is this question of localization. Where do we actually stimulate? And there are a couple of questions to ask here when we're thinking about how we target with TMS. The first one is, where do we want to stimulate? And the second one is, how do we actually ensure that the coil gets there? So when people first started to do TMS, they effectively just looked at brain scans and assumed that the optimal site was in the dorsal prefrontal cortex. And if we localized the motor cortex and just moved the coil forward by 5 centimeters, that would produce optimal clinical outcomes. But there are lots of different ways of doing this, and I'm going to talk a little bit about over the next couple of minutes. So when we first started to address this question, the literature wasn't clear. So we went and we did some functional neuroimaging studies. We particularly did functional imaging where we did several tasks during the same scanning session, because when we looked at all the different studies, they all seemed to have different results. So we wanted to try to almost do multiple studies within the one set of patients and look at the overlap between the abnormalities that we saw. And this kind of confirmed abnormalities in dorsal prefrontal regions that we thought were important. So we went on and then did a meta-analysis of all of the neuroimaging studies that had been published in depression to that time. There wasn't a lot, nobody had tried to synthesize this literature, but we did a meta-analysis at rest. We did a meta-analysis with of the changes that are induced with SSRI treatment, and then a meta-analysis looking at what happens during emotional activation tasks. And if you look at B here, this was the treatment studies. You see this very large red area. This is the area of the brain that increased with successful antidepressant treatment. And this certainly sort of overlapped with what we were finding in our original neuroimaging data. So we thought hard about this, and we ended up choosing an area of the brain that, if I just skip back for a minute, is identified by these so-called Talairac coordinates, and is significantly further forward than you would end up with if you localized treatment by the traditional 5 centimeter method. This was sort of about 2/3 of the way forward in the middle frontal gyrus. Whereas, to give you some comparison, if you were, and going back to that previous study, you know, if you look at this side, the back of this would probably be where you'd get with the 5 centimeter method, and this extension at the front really is where we ended up with our new target. And so we couldn't afford the sort of fancy neuronavigation equipment that you're going to hear about towards the end of this after my talk today. This was quite a number of years ago, about 15 years ago, but we had a very simple neuronavigation system that we used to localize this site off people's individual MRI scans, and we randomized people to have treatment at this site or by the 5 centimeter method, and we found that neuronavigational treatment resulted in a significantly greater clinical outcome. So that's well and good, but is that as good as it can possibly get? Well, since then, there's been a lot of interest in using functional imaging to try to find a better or a more accurate localization site. And so Michael Fox kicked this research off initially with his work using resting state imaging, where the basic idea here is get a resting state scan, put a seed in subgenual anterior cingulate, and then look on the lateral cortical surface at the area of the brain that is most closely anti-correlated. So the area of the brain on the lateral surface that is most anti-correlated with this subgenual anterior cingulate seed site. By anti-correlated, this means that when blood flow goes up in the subgenual anterior cingulate, it's going down on this lateral particular site. And when Fox and colleagues looked at where in the prefrontal cortex was most treatment ended up when it was most likely to be successful. They did a couple of analyses. The data down the bottom here is from patients, and what you see is that the strongest relationship that there was really was with the site that we had identified originally. This was, so it basically meant that if you were being treated closest to this, the closer you got to this site, the more likely you were to have a successful antidepressant outcome. Our group, particularly in a couple of papers published recently by Robin Cash, has done a replication of this data, but has also extended this to a new level where the studies originally done by Fox's group have all been done on group average scans. So to average MRI scans across multiple subjects. What Robin's analysis has shown that you effectively get a relatively large distribution, as shown in slides, figure C here, of where the optimal site is likely to be. It doesn't cluster all in one area. And so what Robin then did was to look at, on individualized scans, would we still see this predictive relationship? And we basically found that the individual predictive relationship produced a significant prediction of whether or not you were likely to get a successful antidepressant outcome. And so this is really promising. It suggests you can do it on an individual subject level, and there's been a lot of excitement about this sort of data. But it doesn't necessarily mean that it's proven yet. It certainly hasn't been shown yet in prospective studies. If you actually look at it, on this slide, I'm just presenting a couple of the different sort of targets. So this FX1 is the so-called Fox target, the one that Michael Fox has shown to have the greatest degree of anti-correlation to the subgenual anterior cingulate. P1 and P2 are two sites that were identified in a recent article by Shan Shadiki from Michael Fox's group, and where he showed that there seemed to be a relationship between specific symptoms and response at these two sites. So that if you stimulated at the P1 site, you got an improvement in a dysphoric or sort of core depressive symptoms, whereas if you stimulated at this P2 site, you got an improvement in anxiety and somatic symptoms. And interestingly, this posterior side is right next to where you end up with if you localize treatment by the traditional 5 centimeter method. And the Fox site down here is kind of right where you end up if you localize treatment by the using the so-called beam F3 method, which is a way of finding the F3 EEG site, but in a relatively straightforward and simple way. Another element of knowing how to optimize TMS treatment is clearly relates to selecting the right dose of how we want to apply our stimulation. And I won't talk about dose at any great length, except to say that we've just last year published this large dose finding study where we investigated the effects of a standard dose or a very high dose of left-sided treatment, or a standard dose or a very high dose of right-sided treatment. And we effectively found that we didn't get a greater degree of antidepressant response with these substantially higher treatment doses, which suggests that we're already at the top of the dose response curve. We're not going to improve outcomes with substantially increasing dose. So maybe we do need to be looking at personalisation if we want to look at clinical outcomes. And one thing I forgot to, I suppose, to mention when I was talking about this data was, you know, if you are using this sort of localization treatment, everybody sort of seems to assume that you're going to get better clinical outcomes, and we should all be rushing into doing clinical trials to prove this. The problem is that the F3, the beam F3 approach, is now the kind of standard way that people do treatment, localization. So if you were to randomize people to personalized treatment using the Fox method, on average, you're going to end up here. If you then give your control group treatment at the beam F3 approach, you are going to end up at the same site. So it's unlikely that using a modern adequate control group, you would show that personalization would be a better treatment outcome. You might get a better treatment outcome if you used in your control group the 5 centimetre method, but that is no longer kind of the standard, standard of care anymore. So it's not clear yet really whether or not somebody's going to be able to come up with an adequate design that's going to be able to prove that personalisation of target is going to improve clinical outcomes above and what we can do currently today. And we can't improve outcomes with just increasing dose. So are there other ways that we can do this? I'm going to skip through this. Actually, no, just before I move on, one other element of dose is just a question about whether turning the intensity of treatment up is going to result in better clinical outcomes. I'm presenting some data here actually from Sung's PhD that he did with us a number of years ago before he went off and left us to go and work for other people now A&T Neuro. And this showed using theta burst stimulation, a somewhat newer and more efficient way of applying TMS, that higher intensities of stimulation didn't necessarily result in greater clinical or neurophysiological effects. And when we did some modelling of electric field distribution a number of years ago, we saw the same thing. What we effectively found was that in the group of responders to TMS, the area of their brain that was effectively being treated when we looked at the E-field, that was the E-field modelling, was actually smaller than the area of the brain that was being stimulated in non-responders. So again, just turning up the intensity of stimulation didn't appear to be a way of producing greater antidepressant responses. So one of the questions is, can we produce a greater antidepressant effect with other forms of personalisation? And one of those is actually individualization of stimulation frequency rather than stimulation target. Now, why would we be interested in frequency? Well, you know, as I'm sure many of you are aware, oscillations are really the language of the brain. Our brain areas talk to one another at specific frequencies, and that underpins cognitive function, and it probably underpins cognitive dysfunction as well. But frequency is really something that has almost universally been ignored in the literature exploring about, you know, how we do TMS. Everyone uses 10 hertz, or everyone uses 1 hertz, or everybody uses 50 hertz when they're applying theta burst stimulation. And we know through the use of EEG, there are ways that we can personalize based on individualizing frequency. So this was, again, data from Sung's PhD, but you know, really interesting data where what he did was he got a group of healthy control subjects, got them to do a working memory task whilst we recorded EEG, and measured both the theta waves and the gamma waves, so in theta range, so 4 to 8 hertz, and high frequency oscillations in the gamma range, and looked at a particular interaction between these two frequencies with theta gamma coupling, then selected an individual theta frequency and an individual gamma frequency. And the reason why he was selecting in those ranges that we weren't looking at individualizing or personalizing standard TMS, but we were interested in looking at personalization of theta burst stimulation. And theta burst stimulation is a paradigm that involves applying stimulation at a combination of theta frequency, usually 5 hertz, and gamma frequency at 50 hertz, although sometimes people use 30 hertz as well. And so Sung used the 30 hertz theta burst paradigm, the 50 hertz theta burst paradigm, and this individualized paradigm where both the gamma frequency and the theta frequency were both personalized. And these squiggly lines you see here are responses to single TMS pulses recorded with EEG before and after an application of these theta burst paradigms. So every subject had 3 testing sessions. In one they had 30 hertz theta burst stimulation, one they had 50 hertz, and one they had individualized, and we measured brain effects before and after treatment. And clearly what happened was there were dramatically greater effects with the individualized theta burst stimulation. And interestingly, Sung also found changes in mood, even though these were healthy control subjects, their mood improved with individualized theta burst stimulation, and they had improvements in working memory-related cognitive function. And so this is a fascinating difference. These were the differences between individualized stimulation and 30 hertz standard stimulation, and between individualized and 50 hertz, 5 minutes and 30 minutes after the end of the stimulation train. And these were quite substantial effects that we now feel warrant testing in prospective clinical data. So we have a clinical trial going on at the moment where we're prospectively evaluating this individualized paradigm. The last way of potentially individualizing stimulation is through working out ways of individualizing the angulation of the coil itself. Historically, we've always just placed the coil at a 45-degree angle to the midline, assuming that was the optimal way of localizing the coil angle. What this data shows is that, without going into too much detail, is that the optimal angle of the coil in prefrontal cortex to induce electrical activity in the brain varies significantly between individuals. And this may well be another element about how we want to individualize treatment in the future. The last thing I'm just going to briefly show you is some data that Neil Bailey, a postdoc in our lab, has published recently from a couple of studies looking at the possibility of electrophysiological data to be used to predict response to treatment. So this was theta connectivity across the brain in a group of patients compared to healthy, who responded to TMS compared to non-responders to TMS, showing significantly higher whole of network theta connectivity in responders who subsequently went on to respond to TMS treatment. And the data on the left is from this working memory data. The data on the right is from patients at rest. And what we saw, what Neil found here was an algorithm that includes this data was able to predict response to treatment with accuracy in this case of over 90%. Now, this hasn't necessarily been replicated with some follow-on studies that we've been doing, but it certainly shows the potential for electrophysiological data particularly using EEG in relatively short acquisition sequences, relatively simple paradigms, potentially to have substantial predictive value and be able to be used to help establish the way in which we both localize treatment, but also then potentially, as I mentioned before, choose the frequencies that we want to choose when we're going about with a treatment paradigm. So in conclusion, we currently have multiple ways to treat patients with TMS and an increasing range of viable paradigms, but we continue to lack certainty with the most effective way to apply these, and there are a variety of ways that we're continuing to explore to potentially enhance our personalisation. And some of the actual methodology, particularly around the neuronavigation, is something I think you'll learn a little bit about in the practical demonstration that's going to follow on from my presentation. So I'm going to finish there and just say thank you to my fantastic research team at the Epworth and a whole series of fellows and students, both past and present. And I look forward to the chance to answer some of your questions after the next presentation. Thank you.